Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are thrilled to welcome Erik Sunset, Chief Revenue Officer at DocBuddy. Erik brings a wealth of experience in sales, marketing, and digital transformation, shaping the future of health tech. From hosting the DocBuddy Journal podcast to spearheading innovations in ambulatory surgery centers, Erik's journey is one of ingenuity and leadership. Stay tuned as we deep dive into Erik's story, the innovations at DocBuddy, and his vision for healthcare. Welcome to Health Tech Heroes, Erik.
Awesome. Thanks for having me. I'm excited to be on your show.
I'm very pleased that you could make time and be here with us, Erik, and I think we are going to have a great conversation here.
Absolutely.
Your career spans from sales to spearheading revenue growth in health tech. Can you share the personal turning points that led you to pursue this space and motivation fueling your mission in healthcare technology?
Yeah, absolutely. It was very fortunate timing that at the signing of the High Tech Act, this was part of ARRA 2009, something that George W. Bush initially drafted and then Obama signed into law. This is what the health tech landscape and the provider organization landscape would better know as meaningful use. So there was a carrot and a stick approach that Medicare took with health IT, where there's big incentives to buy, adopt, and then utilize a certified electronic health record software. So as I'm entering the workforce all those years back, it was really just fortunate timing that tech is so important. It's an everyday facet of my life, just like I'm sure it's an everyday facet of your life, Vasa. So beginning out at sort of the beginning of meaningful use, that was a lot of fun. There was a lot of product flying off the shelves. Electronic health record software reseller. It was a full stack operation. So everything from hosting to services to support to data conversions. Sales, of course, being a part of that. We saw a lot of excitement early on with meaningful use, and fast forwarding a handful of years later and seeing sort of the pain and the struggle that physician organizations went through in meaningfully using their EHR. You have these softwares that are catering towards CMS or Medicare guidelines that we need you to capture all of this data, and you're turning a provider, and that is a physician, a surgeon, nurse practitioner, a physician's assistant, all of those classifications obviously fall under being a provider. You're turning a provider into their own scribe. And we didn't know it at the time, but this would become one of the key drivers of physician burnout as we get from sort of 2015, 2016 up till COVID. It was very obvious this was hurting the profession. And then at the other end of COVID, you see even greater burnout for more staffing related issues, but these legacy softwares really causing physicians to retire earlier than anticipated, driving a shortage of not only anesthesiologists, which you hear about in the news, but an outright shortage of physicians that we're facing. So part of what drives me to continue to change the realm of health IT is delivering software that can give providers more time for life instead of more time for being their own scribe.
I did not realize that this was actually correlated directly with physician burnout. Can you touch upon it a little bit more? How did we come to that conclusion? Because I'm very keen and intrigued on that very specific. You said it was the word you used was a key factor for physician burnout.
That's right.
Can you elaborate that? Yeah.
Yeah, absolutely. So if you go back pre-COVID, you can look at surveys from the time, whether they're on Medscape, it might have been a KLAS research, and that's KLAS research, which is sort of the Yelp of health IT softwares. It's user-generated surveys. It's not the vendors telling you how good they are. It's legitimate user surveys, among many other sources. So when you look at pre-COVID factors contributing to physician burnout, pre-COVID, again, the sole prime driver was around the software in use. It takes too much time. It's too expensive for me. I don't like using it. It's causing me to chart after hours. It's causing me to chart on weekends. And when you don't have time to have dinner with your family, or when time that should be spent at a child's soccer game or other family activity, or even just not work, is being consumed by charting needs, it was very evident pre-COVID that bad software, legacy software, and I want to be clear, I've spent time on this legacy software side of the industry with numerous EHR vendors. everybody at these vendors is working really hard to deliver a great product for their end users. So physicians, surgeons, their staffs. So it's not entirely fair to throw all the spears at your legacy EHR vendor when they're simply writing software that takes into account the quality reporting that Medicare requires, the submissions to registries for quality reporting to make sure all of these features are in place for successful reporting. Obviously, the other pre-COVID prime drivers of physician burnout were around a lack of autonomy. So if you're at a health system, I can't practice medicine the way that I really want to. I have somebody above me telling me how I'm going to treat patients. And then there's another handful of sort of lesser points driving pre-COVID burnout. When you look at the same studies from the same outlets post-COVID, it's no longer bad software that takes too much time to use. That's the prime driver. Now it's around a lack of staff. And bad software is still very much in that sort of top 2, top 3. It depends on which survey you're looking at. There's a lot of really good ones. I have yet to see kind of a bad one where the data wasn't intuitive to me, and maybe that's more of a statement about me than of the surveys. But post-COVID, and we're still seeing the ripple effects to this day, sort of like the 2022 timeline to present, where it's really tough for a physician organization to hire staff, let alone get anesthesia coverage, let alone be fully staffed in terms of providers. So it's something that is absolutely hurting the profession. And we're doing our small part, like I said earlier, to give providers more time for life and get them out of their EHR and help them to do what they need to be doing, which is practice at the top of their license and not be doing that at every hour of the day.
Few things I did not appreciate enough before the last conversation was 3 parts. The first part was it was a sole driver before COVID. And the second part is it is second or third issue in the survey, but still it's not a problem that is solved. The level still exists. It is still has a very high impact, but there are other issues above it. Now it is getting compounded above this. So we have other bigger issues, but we need to also solve this issue right away, and again without the staff. And the third thing I think was very striking for me was you're not just talking about like taking away healthcare workers away from the patient. You're talking about like after job, taking them away from their family too. So it's not just that this is taking them away from bedside, but also the family. So I had not caught on to that nuance that it is actually taking them away from their family as well.
It's a big problem, Fasa. And when you look at the current fee-for-service landscape that most of the country is still in, and there's some innovators around value-based care and all that, that's a whole other conversation. What is value-based care? How can I participate? You get 100 different answers if you ask 100 different people. But where it's really hurting these fee-for-service physician groups, your office visit type providers, you're not necessarily having less time with an individual patient, right? It's kind of the expectation now. You're with your doctor, hopefully not often. Hopefully everybody in the audience is healthy and isn't dealing with any chronic issues. But if your physician has to type a few things into a computer, that's pretty normal now. Maybe they have a scribe. Maybe you see them talking into their Dragon, or if they're one of our clients, you see them using our DocBuddy solution. But where that really hurts these fee-for-service organizations is it's not that an individual patient has less face time with the provider, although there's a case that can be made that their full attention isn't necessarily on the patient. It's when you need to see a certain number of patients per day, but because of your charting requirements in these legacy softwares, you're now eating into time you could be serving patients because you have to finish the note from the last one. And then over 30 visits, 45 visits, 60 visits a day, sometimes that's a lot of time.
Yep, 100% I appreciate that. Hosting your podcast, the DocBuddy Journal, what inspired you to do so? Is there any emotional connection to it that takes you and like allows you to do this and do this well?
Great question. So that's kind of multifaceted. It's probably obvious to your listeners now. I like to talk. I've got no shortage of things to say. So to have the podcast and to be able to converse with guests and hear about what surgeon, physicians, but business office manager, but those in leadership positions that healthcare systems are seeing is really important. Kind of selfishly, I get to take a pulse of the market from those on the front lines because I have not worked in a medical practice. Spent a lot of time in them and a lot of time in surgery centers as well for that matter, but always on the vendor side, right? So it helps me to better understand the challenges that our healthcare workers are facing. Obviously in exchange, and it's all for fun, it's all collaborative. They get a platform to share their expertise. There's also another reason to this, and that's just how much marketing has changed in the last 5 and 6 years. You know, the long form SEO piece that this is going to be a slam dunk. These are going to be top ranking for these keywords that I really like. And you may still get that ranking, although that's changing. And we can go into Google's AI overview and sort of LLM search results a little bit later. But you need to meet people where they are, and reading is not where most people are. You know, we've got a lot of great content on our site, but people want to watch, want to like, they want to share, they want to engage. And I find that it really humanizes the brand. Particularly so, I have a co-host, one of my colleagues, Kira Helms, who does a fantastic job with our more philanthropy related episodes as well. So episodes with One World Surgery. Highly recommend that. It's transforming. One World Surgery transforms lives across the entire Western Hemisphere, providing needed medical care to those that would never otherwise have it. And then even the Dr. Lorna Breen Heroes Foundation, raising awareness for physician mental health. A tragic story for Dr. Lorna Breen, but coming out the other end of this tragedy, doing great service to those who are facing mental health, who are taking care of patients at the same time. So long walk for a short drink of water there, Fasa. It's great to understand the market from those that are living through it. Then it also fulfills a really important marketing function for us as well.
Terrific, Eric. I think, talking about healthcare and health tech, having a long walk is a good thing for a quick bite and for a small drink of water. When you spoke about the philanthropic part of your podcast, I can see your face light up. What drives you? Was there an incident in your life that you'd like to share? What is a personal reason?
Well, there's a lot to pull from there, and this is a little bit of an extreme example, but going back in time to the early days of meaningful use where physician practices were buying their first EHR, maybe they'd had a practice management system that they had come to love over the last 15, 20 years, but now you need to buy something new. Medicare effectively was saying to the market, you buy this software that we certify, and we say is good for you to use, or we're going to reimburse you less. That's the trade-off. If you want to see Medicare patients, you either buy the software and use it, or you're going to be reimbursed less. That doesn't feel great to a physician who went through medical school, went through their residency, went through their fellowship, does continuing medical education. They want to treat patients. They don't want to be their own scribe. They don't want to be doing data entry. And that, frankly, is a terrible use of their time. They should be treating patients, doing what they love. And that gets into a broader conversation around reimbursement and how that can be more fair. But going back all these years, when I was at this EHR reseller, I later went on to lead and then lead the acquisition thereof. Having pediatrician clients, so having pediatric clients ask me, why do I need to record a smoking status for a 3-year-old? I didn't write the rules around meaningful use, so I don't have a really great answer for that. I'm sure it happens that there are 3-year-olds that smoke. Probably not a whole lot of them, and hopefully none, if you ask me as a dad to 2 young kids. But Eric, why do I need to do this? What's the point? And there's 100 other examples I could give of why am I needing to do this in this software? Number one, smoking status for children under the age of 5 seems a little silly. And number two, it's taking so much of my time. Like we've already said, I'm missing dinners with my family. I'm having to chart. They call it pajama time charting. You know, you come home, you eat dinner, you throw on your PJs, and I still got to open up this laptop, finish my notes for the day. That's unacceptable. There is no other industry that is still using fax, and for the most part, I think is now using encrypted email, although unencrypted email is still very much a part of healthcare. It shouldn't be. You shouldn't do that. Talk to your lawyer about why you shouldn't. Talk to your compliance officer why that's a bad idea. But there's no other industry that accepts that these workflows are normal and acceptable even. Healthcare does. So that's a big part of what we're doing at DocBuddy is to move this status quo mindset of driving to Blockbuster to rent your movie for the weekend. You know, you got to get in the car, go there, pick it out. Hopefully they have the movie you want, rent it, and then come back and drop it off. Like that's very much the old way. That's very much how most of healthcare is operating today. And the rest of industry, and what we seek to change at DocBuddy is to give them Netflix. And I mean Netflix in 2025. You're able to watch anything on demand with the click of your remote, with the tap of your iPad, you know, wherever you are, you can get movies. That's how data and that's how documentation should work. And again, that's what we are actively changing here at DocBuddy.
That's awesome. And my next question was about DocBuddy. DocBuddy is transforming ambulatory surgery centers. Can you explain the core problems that you're solving with an example, like how would it look in a live situation, and
Yeah.
how do you distinguish this from your competition?
Absolutely. So one of the biggest problems that ambulatory surgery centers have, or ASCs, or surgery centers, or outpatient surgery, however you want to phrase it, but we're talking about the surgery center. They were exempt from this Meaningful Use Act that we've talked about a few times. So there's no need for an ASC to purchase an EHR. And a lot of them did. We've got a lot of good friends at the core vendors in the ASC space that deliver EHR solutions. Love working with them. They're a very necessary part of the ecosystem, but there's still not a ton of actual tech penetration into the ASC. So most ASCs have a practice management software, and then there's any number of ways that surgeons are generating their operative reports or their op note, all the documentation needed for that procedure. There's a patient safety aspect as well, that once you are post-op, there needs to be an immediate post-op note. What did I do? What are the potential challenges for this patient? So that transition of care to the nursing team, when they get into the PACU or post-anesthesia care unit, post-op, somebody can be aware of what needs to happen. And I'm jumping tracks a little bit, but this generation of documentation, being able to access it, create it, and then move that data is something that ASCs, without DocBuddy, and I can confidently say this, without DocBuddy, it is a manual process for those at the surgery center to accomplish these ends. So not only is there a patient safety aspect to this as well, but there's also a billing and financial aspect. Some of the listeners are probably familiar that there's a professional fee that the surgeon bills out of their practice, and then there's a facility fee that the ambulatory surgery center bills. We're able to encapsulate all of these work streams into our OpNote app, where the surgeon gets to use the workflow that they really like and that they prefer, just talking, dictating. They use our phone to generate their operative report right here, right now, in real time. They're able to sign that from their phone. So that's the creation of the data, right? And they're able to access their schedule from the DocBuddy app. And then the movement of data is where there's a huge difference, because this is staff time. This is labor time if you don't have DocBuddy. And like we said, it's very difficult still post-COVID to make hires and retain good staff. So we're able to wipe that out as a need, that wherever that operative report needs to go post-op, whether that's to your revenue cycle vendor for coding the claim, whether that's back to the practice's EHR, which we're integrated with many practice EHRs, and then integration back to that ASC's core EHR software. To put it in a nutshell, Fasa, it's the creation, accessibility, and then movement of the data, which is still stuck in the Stone Age for so many surgery centers.
May I ask a couple of follow-up question on the DocBuddy aspect? So all the systems are different. How well are you able to integrate with different centers? That would be my first question. And there has to be some quality difference between the voice notes and the written notes. Can you shine some light on it?
Yeah. So to our customers, to our dear valued customers, they know us as the app that they use. We're a web portal that some surgery center stakeholders use to oversee their operative report supply chain. But at our core, we're really an integration business, because without that movement of data, you're just a really fancy notes app like you already have on your phone, right? We can't forget about HIPAA, but if HIPAA wasn't a factor, you just do all these notes on your phone. To an extent. But being able to then move that data where it needs to go in real time, that's a huge differentiator. And then to answer your second question around the quality of notes between what we offer and maybe doing it on your computer or using something like Dragon, where it's you talk, it types, what we find is that we're able to offer some sort of revenue cycle advantages where these other modalities are lacking, that with our voice commands, we're able to really firmly standardize a note either down to at the facility level for all providers doing this type of procedure at a given ASC, or even down to surgeon specific preference. The great example that I can give there is that we had a client come to us and say, hey, I'm getting a ton of claims denied when we use Exparel, which is a drug a lot of orthopedic surgeons and general surgeons use in the course of their procedure. We had a client say every claim that had the use of Exparel was denied because the surgeon wasn't capturing that in their operative note. Can you help us? And the answer is yes. Within the surgeon's voice commands, we're able to tag that out as a line and as a helper phrase, like, did you use Exparel in this procedure or not? And if they did, they notate that they did. If they didn't, that line can come straight out with simply using their voice to drive the note. So that's a big difference, is being able to standardize on the front end for revenue cycle. With our OpNote app, your days unbilled is going to come down from probably 15 days on average for the normal surgery center down to less than 3. So you're able to file that claim and begin the revenue cycle process faster. And then you're also able to reduce the amount of denials you get for standard procedures where there's a certain system, or the word I'm looking for is modality of treatment, like in the case of that expiral example. So their denials for expiral related claims is now 0 because their operative reports are more standardized.
So let me hear this metrics. Let me wrap my mind around this metrics. 15 days to 3 days. And second is from all of them were denied to 0.
Correct.
I just wanted to repeat those because those are fascinating numbers.
Yeah, and I'll dig into them just briefly. I know we're getting a little long-winded here. Maybe happy to continue the chat as long as you'd like, Fasa. That unbilled days metric is interesting because this is that Blockbuster and Netflix analogy all over again. If the way that a surgery center is currently generating and signing and like the finalization of the operative report is a big deal. If your process today has any amount of waiting in it, so it's got to go out to transcription, maybe, and then it needs to come back, then the surgeon needs to read it, and if it's right, they sign it. How much time did that take you? You probably get the transcribed report back in a day or two, depending on your level of service from your legacy transcription vendor. But when's the next time you're going to see that surgeon to sign it? Are they going to remember if they can do it electronically, or do you have to ask them? So that 15 days on average of a days unbilled. So the procedure ended at this time, and then how many days until you have a signed operative report that's ready to go to the coding team? And then when are you able to actually submit that claim for reimbursement? You know, these ASCs operate on razor thin margins. So to wait on money that you've earned is insane.
This type of service was just to get my timelines correct. This was the pre-AI era. You had this type of services, and if you did, the AI is going to be another huge thing. We can come to that shortly. Okay.
Let's talk about AI here just briefly. In the case of our OpNote app, there is AI and machine learning that happens on the back end to help drive that individual user's voice profile. The accuracy out of the box is already 99%. And then as you use it more and it's dedicated to just an individual profile, it gets even better over time, and it learns sort of the odd things that you may throw at it, like an anesthesiologist's name that might be tricky to spell. It will learn how to correctly spell that through its use. But we get asked this frequently. So OpNote, is that an AI tool? And healthcare is in a funny place because everybody wants AI. Not everybody knows what it is. Hardly anybody knows how it actually works. So I always come back when we're talking about OpNote. What kind of conversations do you think are happening in the OR? Like, think about it. There's not a ton of conversation happening in the operating room, and I always joke that that's probably not a conversation that you as a surgery center would want recorded either. Who knows why? But with OpNote, it really is not a front-end AI tool, and we find that we get asks for that feature to be built, but you're going to end up being faster without needing the ambient listening, because that's what we're really talking about for documentation purposes and healthcare using AI. That's great. And we have an AI Notes app even that is an ambient listening note taker that is fantastic in the clinic setting where you're having this conversation. Oh, you're here to see me today. What's going on? Oh, doc, I got the flu. My throat hurts, blah, blah, blah. And then you go through that patient-provider interaction and you're able to extrapolate out whatever type of documentation that you need. But in the case of OpNote, there's no conversation in the OR. And again, probably not a conversation that you'd want to have recorded as a surgery center. To be totally frank, who knows what was said? Who knows what music's on? So you end up being faster without ambient listening on the surgery center side of things. Not necessarily the case on the practice side of things, though.
And just to pin my timelines, you have been doing this pre-ChatGPT, right?
Yes, that's correct. Okay. We've been around since 2014.
And NLP and ML had already started catching wind in 2013s and 2014s. It's just that it came up front with ChatGPT for consumer.
Right. Exactly.
Wonderful. Since I've been with DocBuddy, is there a experience with a system or a center that is very personal to you? You thought that, hey, that type of testimonial was pretty amazing from your perspective about DocBuddy's win. What would be that testimonial?
That's a really good question. So when we're at state surgery center conferences and national surgery center conferences and events, a lot of our branding and a lot of our marketing centers around instant operative reports, because that's what we do. And if somebody isn't familiar with DocBuddy and sees our messaging, a lot of times they walk up to whoever's in the booth and they say, I don't believe it. Instant operative reports, like I'm waiting on this, I'm waiting on that. Like, I don't buy it. Like, that's a lie. You're not being truthful. And we say, it sounds almost too good to be true. I assure you that it is. Do you have 30 seconds? And you're able to show the product, their eyes light up. And in terms of testimony, when it's actually in use, when it's at a customer site, the feedback that we get is that we can't believe how fast it is. And fast means a lot of things to a lot of different people at the surgery center. So for the surgeon, fast means I can do my entire operative report, sign it, and then move on to my next procedure using DocBuddy. Fast for the business office manager is I don't have to wait for surgeons to sign their operative reports anymore. And then when you're looking at the revenue cycle team, fast is more along the lines of I was able to file this claim for a procedure we did today because it was done, the operative report was complete, I got it coded, and it's off for payment. So that's really gratifying, especially coming from the EHR, the legacy EHR side of health IT, where you're not really going to be anybody's favorite vendor. You may bend over backwards for them, ensure they have everything they need to be successful. But when they see you in their email or they see you walk into their practice or their clinic, they go, great, good to see you again. On the other side of this, though, we've got enthusiastically satisfied customers that rant and rave about how easy and how fast it is. That's really gratifying, Pasa. I'm glad you asked that.
I'm glad to hear that. And I can almost envision when you say, like, give me 30 seconds and their eyes light up, that means they're essentially can walk from one patient to the other patient and they can file this report. And you said you have reduced the time for the reimbursement from 15 days to 3 days. That means you're basically submitting the claim right away, and the 3 days lag is basically on the other end that we don't have control over. Is that
Correct.
what it is? Okay.
Some of that we don't have control over. So the reimbursement timeline can vary. I'm that 15 days to 3 days. I'm talking about days unbilled where you have a claim to submit, but you can't because you don't have a signed report or it's not coded. So with DocBuddy, you're in total control of that. Once the claim is submitted, obviously that's up to the payer. Hopefully they pay you fast. But just for clarity there, that's what I meant.
So on average, you have reduced it from 15 to 3 days. And sometimes most efficient is you're able to do it the same day, effectively.
That's right. There's only as much slack in the process as the facility allows. For a subset of our users, they have finalized op reports in less than 24 hours, which is unheard of in the Blockbuster days.
Okay, so technically, if the facility decides to focus their resources on this and be super efficient, with DocBuddy, they will be able to do all their reports within 24 hours. Is that what?
That's right.
Yeah, okay. That's amazing. And every success story has challenges as well. What kind of challenges do you face?
The biggest challenge, we've kind of touched on this a little bit, but it's around the status quo. You've got this healthcare industry that, I'll say it again, they're still faxing documents back and forth. What other industry faxes? Like, you might have to send the IRS a fax. It's really just healthcare and the federal government, though. And is that really good company? Not to me. So there's when you're creating a category, really, which is what DocBuddy is doing and has done, when you're creating something new that hasn't ever been seen before, the only reluctance is we've been doing it this way for so long, I'm not sure we want to change anything. But then that's when you have to get into some of these deeper conversations and these deeper points that while DocBuddy's not a revenue cycle vendor, there's a lot of great revenue cycle companies out there that will do all your billing. We're really the front end of that revenue cycle, though, because without documentation, what are you going to bill insurance for? There's nothing to be reimbursed for until you have documentation. So when you initially overcome that status quo type objection and really start talking about the value of getting paid faster, less time for staff spent on administrative tasks, and you have happier surgeons, it becomes a slam dunk. And again, when you see the tech, it's like nothing else out there. And again, we're just so happy to delight our users in an arena where traditional health IT has not really delighted anyone.
It looks like the limitation is see the tech. When you see the tech, that's the limitation. That's where I think coming down to. Could have been one sentence. You have been a part of an initial transformation in this field and you have seen it all. effectively when it comes to this health tech. From your perspective, we are like from everybody's perspective, we are going through a transformation in every field. But from your perspective, where are we going to be in like next 5 to 10 years?
We're going to be in big trouble, Fasa. I mentioned this earlier. There is a known shortage of anesthesiologists in the market in the US. That's making the news now. That's making your cable news. Not often, not as often as it should. But it is beginning to be talked about. There's certain states that have lifted the requirements for CRNAs. So you have some states that allow certified registered nurse anesthetists able to practice without MD oversight, so without anesthesia oversight. That's a nice band-aid that's needed because I don't know about you, I'm not getting any surgeries done without anesthesia. I mean, that's tongue in cheek, but obviously you will not be having that procedure you need without anesthesia. That's a very difficult problem to address, a shortage of anesthesia providers. There's an equally difficult problem to address, which is the shortage of physicians. I'm very concerned about what's happening with the population of practicing physicians because coming out the other end of COVID, you've seen retirement at a rate for physicians that was unexpected. It's that their physicians are retiring much earlier than anticipated. And I certainly support the individual's right to do what they want. You know, you can't compel somebody to practice medicine. But the rates at which providers are retiring early, switching careers, this is a big problem for every healthcare consumer in America because we are on the edge of a cliff where primary care wait times, I can speak to Miami, 8 months to be seeing primary care. There's another sort of sub-factor to this where there's so much money now in healthcare that is willing to buy practices and employ physicians, and you're seeing the independent practices go away. And it's for reasons we've already discussed. Too much tech, too much burnout, not enough staff. I got to compete to pay wages with the hospital, which is always going to pay people more than my private practice can. What's the point? So between this mix of the providers left practicing, becoming employed, and then the en masse early retirement of providers, it is going to be exceedingly difficult to receive healthcare, and it's going to get tougher every day until we get to 2030. I don't know why cable news isn't talking about this yet, but the country is in big trouble when it comes to receiving any amount of care. So what can you do? There's certainly a conversation to be had around reconfiguring how folks go through medical school. There's conversation to be had around reimbursement to make it more attractive to become a provider. Because if you think about the amount of schooling and the amount of time and effort and money it takes to go through medical school, your fellowship, your training, board certification, so on and so forth, and then out the other end, you're saddled with this huge student debt bill. For what? To go be abused by the payers for the rest of my career and not get paid what I should be getting paid for treating patients, saving lives, improving the health of others. That's probably not the answer that you were expecting, but we have some fundamental mechanics that have to change for healthcare to remain sustainable in America.
I want to pivot a little bit here from a health tech perspective. You said too much technology in one of the sentences is an issue, which I understand. They're like too many passcode. It could be like just too many passwords, like too many things to connect to. From a technology perspective, do you think there is a solution? I understand we need more doctors, so we just have to have them graduate with lower debts and better incentives. Is there a technology solution you think that can alleviate this a little bit?
I think some of that technology solution comes down to reporting requirements, because a lot of the complaints that you hear from the legacy side of health IT, so your big EHR vendors, or even your not so big EHR vendors, they have to provide software that allows practices and physicians to attest to their meaningful use and be able to participate in all of these quality programs. I don't think the quality programs are necessarily a bad thing. That was part of the bargain, right? To get healthcare digitized in America, as we now need data on what it is people are being treated for. Is this chronic care issue? Is this more episodic? There needs to be reform for what is being asked for from the federal government and from the states, so that the physician load in terms of charting in this technology is lessened. And then the other aspect of this too, in terms of technology, when you have payers that are leveraging AI to auto-deny claims and use their own LLMs as sort of the nuclear arsenal to deny claims that maybe should be rightly paid, we're gonna see in the next 18, 24 months, that'll be commonplace for your practices, your ASCs, and hospital billing departments. They'll be armed with their own medical grade, weapons grade LLMs, and you're going to have AIs going back and forth with each other, or LLMs going back and forth with each other from the payer to the facility. It's denied. No, it's not. Here's why. Well, it's denied for this. Well, it's actually not denied for this. Read the contract. And it's just da 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 da. The payers are a big problem in the system, and they're what's keeping a lot of folks from pursuing medicine as a degree. So that was I probably need to get off my soapbox a little bit to maybe fully answer your question. Going into this 15, 16 years ago for meaningful use, there's no standardization for software architecture. So one person's set of patient demographic fields might be, or one vendor's set of demographic fields may be wildly different from the next vendor's. How do you make those two things talk to each other? Well, we tried that with regional HIEs, of which there are only a handful that are operating meaningfully, still around, 15, 16 years later. There's groups doing work. SureScripts is one. The Commonwealth Health Alliance is another, to sort of standardize data, create these data exchanges across softwares. Whether that's a meaningful endeavor, I think, is up for debate, because if you're only able to exchange a PDF of somebody's notes, that's not data you can report on. Those aren't qualitative fields in the software. So another sort of foundational issue that went unaddressed from the beginning, and now we're seeing the third order effects of it.
Thank you very much for that view. And I thought that LLM versus LLM conversation, it would be funny if the stakes were not that high.
Right.
Right. Yeah, and thinking about the consolidation on the payer side also, their LLMs are going to be pretty robust.
Absolutely.
For they are pushback and what happens to the small practices? Will they be able to push back at that level?
We're already seeing the early answers there are no, when there are so many practices being absorbed by health systems and by big groups backed by private equity. That's money is the equalizer here. I happen to be of the belief more independent practices are better than less, and it's sad to see that population is shrinking.
As a last but one question, what would be your advice to the entrepreneurs or leaders who are getting into this field? Remember this one key thing before you embark into this journey, because you are going to have impact on this field. But do not forget this. This is a really critical thing for you to remember when you are impacting the field. What would be that advice?
I think the most important thing someone setting out into health IT would need to keep in mind is that the provider encounter, that actual visit with the physician, is what makes medicine go round. There's a lot of steps that go into that. So there's certainly a registration and a scheduling process, but nothing happens until the provider treats that patient. My recommendation would be, don't build something that only works in a vacuum and that doesn't address all stakeholders in a practice, in a hospital department, in a surgery center. Going back 10 years, there were a number of sort of point solutions to do one sort of EHR add-on activity really, really well. Well, if that doesn't address something that matters to the physician and to patient care, I would question its utility outright. Keep the physician in mind. Even if it's not something that they're necessarily going to use, it needs to augment their productivity. It needs to help them stay out of their EHR. It needs to ultimately allow for better care.
Okay, so your answer was, I think in my mind at least, was double layered. It was like, keep the physician in mind. That is very clear. And their efficiency. But also the other layer was, it should, even though you might be addressing a pain point in one vertical, make sure that it connects with other verticals so that everything is focused on physicians' efficiency. So is that what I'm understanding? So essentially, keep two things in mind. Keep physician, even though it might not directly impact the physician, keep physician in mind. And the second thing is, even though it may not, you may feel that it may not impact other departments, don't work in a vacuum, but have a holistic view about all the other departments. That's where you're coming from, right? I think it's a very critical learning for me when I think it.
Yeah, that's perfectly encapsulated. Exactly right.
Thank you very much. So as a final question for you, I typically give 90 seconds, but if you take 4 minutes, I won't hold it against you, which I have a feeling you might. Like if I missed any questions, anything critical question, or if you want to reiterate something which is you're passionate about and you think is super important, go ahead. It's your question, it's your answer, and it's your 90 seconds to 4 minutes.
Boss, I appreciate the latitude there. Really enjoyed being on your program. I think the only thing I would add is you called out, we've got our podcast, the DocBuddy Journal, where we talk a lot about health IT. We get a lot of experts on the show. If that's of interest, you can find it on Apple Podcasts, Spotify, YouTube, or DocBuddy.com. And thanks for the opportunity to promote our show here. Have really enjoyed the conversation.
Okay, thank you very much, Erik, and I really, really appreciate your time here.
Yeah, thank you. It's been a pleasure to chat with you, Fasa. I enjoyed it very much.